is 8:30, and so we're going to get started. I'm Lowell Tong, Executive Vice Chair of the department, and hello to everybody in the room and everybody out there in Zoom land, watching in the comfort of your own computer or at the VA or the General or other sites. Today we're having a presentation by our very own Maga Jackson-Triche, who's presenting a talk titled Transforming Mental Health Systems to Meet the Challenge of Population-Based Care. Maga joined the department and Langley Porter Hospital Clinic and UCSF Health in 2016, being recruited that time from her previous position as Chief Mental Health Officer for the VA Sierra Pacific Network with the VA Veterans Health Administration. What we all think of as the VA. They've gone through several name changes. And since 2016, she's been our Department of Psychiatry Vice Chair for UCSF Health, and also UCSF Health's Vice President for Adult Behavioral Health Services. Yes, this is a lot of names and words and systems, and in fact, that's what she's going to be talking about, complicated world of systems. Maga graduated from medical school at the Pritzker School of Medicine, University of Chicago. She spent some time doing research in Zaire. After that, she completed an internal medicine residency at LA County Martin Luther King Jr. General Hospital, and then she did psychiatry training at UCLA, finished her residency there, including being a chief resident, and that wasn't enough. In the 1990s, she returned to school to get her MSHS in the school at the UCLA School of Public Health in Health Services, and she's one of our colleagues, and she's going to talk to us about systems. So please welcome.
Okay. What I told them is I can't stand at a podium, so I'm going to walk around. And good morning. Thank you. I'm really happy to be talking about this. What I decided to do is sort of give a broad overview. I'll start by a broad overview of sort of systems thinking and some of the issues that are going on in healthcare and in mental health care in particular, and then move from that into talking about access, which is a huge issue generally, but a particular problem in mental health. And then I'll end by talking about Langley Porter and some of the current issues of where we'd like to go in the future. And so I'm going to try to get all that in 45 minutes because I'd like to leave enough time for questions. But since I've been here, people have asked me a lot of questions about, well, what's going to happen? Because it's a very confusing time. Langley Porter is an old and esteemed institution, and it's been doing very well, but the circumstances and the environment around the institution have radically changed in terms of what's going on in healthcare. And it's happening very quickly. An example, when I was recruited here, we were talking a lot about what was going to happen to the Affordable Care. And now that's like, whoa, we still don't know, and we thought we were going to know a little bit more about that. But so let's just go ahead and get started. So we'll meet. All right. So the Institute of Medicine has been very concerned about healthcare, and one of the reasons why is, though we're a first world country, our statistics and outcomes when we look at health are not first world. We're really closer to a third world country, and people are saying, why is that? With all the technology we have, with all the money we have, what's going on? And so the Institute of Medicine took that on, as did the World Health Organization. And one of the quotes that I thought was really important, this is a study that they did and published, Crossing the Quality Chasm, a New Health System for the 21st Century. Which, if you get a chance to read it, is very enlightening about where they see and where we see the future. But they said, as medical science and technology has advanced at a rapid pace, the healthcare delivery system has floundered in its ability to provide consistently high-quality care. And that's really, really very tragic. So the outcomes do not look good in terms of where we want to be. And as you see, in terms of comparing us to our Western counterpart countries, our outcomes really do not look good. And when you start looking at mental health, which I'll talk about a little bit more, we have a hard time even measuring outcomes and figuring out what's important to us and what's important to the population when you're talking about population health. The next one. One back. So the World Health Organization has also been looking at these issues because they started out really addressing issues in third world countries, but they started realizing that healthcare in general is an issue, that our outcomes do not match the technology that we have available. And then the technology has not been widely disseminated. Even if you look in the United States, the urban centers really have access to very high technology, but if you look at our rural populations, you'll see that they have a lot of trouble getting in to see clinicians at all, any kind of clinician, let alone a mental health person. For a while, I spent time in Louisiana and in Mississippi. And in Mississippi, everybody has to go to Jackson. You know, it's a large state, but to see a psychiatrist, you have to go to Jackson. And for much of the medical health care as well, if you need anything beyond just fairly simple primary care, you have to go to an urban center. So it's not widely dispersed, so there's a lack of equity in terms of availability of things throughout the system. So World Health, we're going to go back, I still haven't talked about that one. Taking a systems perspective and orienting systems to the delivery and improvement of quality are fundamental to progress and to meeting the expectations of both populations of healthcare workers. And that's pretty self-evident, so now we'll go to the next one. So what did the Institute of Medicine say about the 6 aims of high-quality healthcare? And this is a consensus document that went through a lot of vetting throughout institutions and through their members and had a lot of consultants. So, and it seems pretty obvious that the 6 aims are that it be safe, that it be effective, that it be patient-centered, timely, efficient, and equitable. And I was very happy to see that they added this, because that hasn't always been the major concern about equity in terms of availability of care. The other thing that hasn't always been very front and center is patient-centered. And so you'll see that conversation now a lot about asking our patients what kind of care they want. What would they need to have to make them feel like they were being well taken care of? You know, for much of our work as clinicians, we were sort of telling people what they needed. And now we have an activated population. Not all populations, but many of them, especially around San Francisco, are activated in terms of wanting to have a real part in terms of their care. All right, next that way, thanks. So the national quality strategy domains, patient and family engagement, and how to do that. That goes all the way from social media to even talking about having groups of patients come in as consultants to the system to talk about that, having councils and panels of patients. Patient safety, care coordination, which is a very big one. As we know that, in fact, this is one of the biggest problems that patients complain about. So they'll come and be seen in one setting, and they'll need care in another setting, and the people never talk to each other, even though we have an electronic medical record, which would make it seem as though we're able to talk to each other, we're able to read notes, but we're finding out that that's not happening. So there's going to have to be more of a focus in the system about that. Community, population, and public health. Again, for the population, the efficient use of healthcare resources. That's a big deal, and as you know at Langley Porter, we're talking a lot about that. What are our resources? How do we use them? How do we make sure that we're using them in the best way possible to provide the best care possible? Which is really a very complex and complicated issue, and effective clinical care. And I think that sometimes clinicians are a little blind about that. Our patients really do like us, and so they know we want them to get better, and so they'll often kind of say they're doing a little bit better than they actually are. And so we need data, and I'll talk a little bit about rating scales and things like that to help you really get a sense of what's really going on with your patient beyond them saying, I like you, and I know you want me to get better, so I'll kind of tell you I'm doing a little bit better than I may be doing. Okay, next. So the 10 rules that guide redesign of healthcare, care based on continuous healing relationships, and the operative word is continuous. So you don't want episodic care. You want people to be able to have clinicians. Now, it may not be an individual clinician. It may be the whole system that makes the patient feel that they're well cared for, well surrounded, that the clinicians are talking to each other, that when you come in, that you still will get the high quality care that you need. Customization based on patient needs and values. And some people are taking that to a very high level. There's a young man at UCLA right now, Armin Adanian, who has been working with apps. He actually came and talked to our digital core about a year ago. But he's even working on having apps between clinicians and patients that they modify for each other so that they really deal with exactly what that patient needs and what the clinician wants to communicate. So this is really an exciting area for the future. And we should probably have him come do a grand rounds here as well to talk about that, because he's right down at the patient level customization. The patient is a source of control, meaning the person tells you what their goals are. Joint Commission has been focusing on that a lot, and they look at charts to see, did you find out what the patient wanted and what their goal is? Their goal may synchronize with the clinicians, but it may not. There may be something else that they're concerned about. So even though we want to give a person the best care, we want to find out, what's important to them as well. Shared knowledge and a free flow of information. That doesn't always happen, unfortunately, but we're trying to get better at that. Evidence-based decision-making, and we know what that means is guideline concordant care. Now, one of the problems with guidelines is that they're just that. They're just guidelines. And they don't wind up being very specific. But what they're good for is helping lead someone through the process of thinking about an illness and what kind of steps you want to consider. You may not want to do every single one given your patient's condition, but you do want to know what the evidence shows. And that's vitally important that we're keeping up with the literature and finding out what's happening. That's the best we have in terms of that. And the evidence changes, and you have to modify and change with the evidence. Safety is a system property, where many of you will be very familiar with that as ligature risks and things like that with inpatient. But there's some of the equivalent things that go on in outpatient in terms of whether that's a safe environment for people when they come in. Are they able to get through with not harming themselves? And then it goes all the way down to the little thing about you don't want carpets that people can trip over and hurt themselves. So that would be a systems issue, right? The need for transparency, which is in some way, that's kind of the hardest for many people. You sort of say, well, what will be the impact of me telling someone this? That happens in mental health a lot. With medical records, many times I was asked over the years, and some of you have probably been asked, is to review a chart to see what kind of information you can share or not. I think that error is going to go away. I think we're going to have to, whatever you write can be seen. And so we're going to have that as a core value that what's in the chart, someone's chart, they can see. You don't have information that's in that chart that won't be seen. And so it's going to have another burden of how you document. And we'll be talking about that, not in this talk, but eventually we'll have to confront that. Anticipation of patient needs, that's pretty obvious. Continuous decrease in waste, and we talk a lot about that when we talk about our lean kind of training. That means either wasteful processes, meaning that they don't add value to the work that you do. If it doesn't add value, it's basically considered waste, meaning you want to just sort of get rid of it. And then cooperation among clinicians, which that's sort of a goal. It surprisingly doesn't happen as often as we'd like because people don't always agree. They don't always have the same approach. But when you're dealing with the same patient, you really do need to have that. So, okay, these are the rules that should guide redesign in healthcare. All right, let's move into talking a little bit about mental health and the situation. This is a landmark study that's been done. It's really pretty old, but the situation is still pretty much the same, which is why I'm showing it again. The provisional estimates indicate that at least 15% of the U.S. population is affected by a mental health disorder in 1 year, right? So that's actually very high. But in 1975, only 1/5 of these people were served in the specialty mental health sector, which is like 3%, and with about 3 identified in the general medical primary care sector. So you've heard a lot about the interest in moving mental health into primary care settings. This is why. Because most of the people who are coming in with mental health disorders, either recognized or unrecognized, are not being treated by us. And so that's a big issue in terms of quality, and people like, people at University of Washington, Jürgen Unitzer, and a lot of other people, Wayne Payton, been doing a lot of work in trying to increase the capacity of primary care to take care of mental health disorders. That's a structural change. We'll talk a little bit about that. But also, we've found that moving mental health into the primary care setting, and now it's actually moving mental health into all sorts of settings so that those issues can be addressed in a high-quality way. So let's talk a little bit about kind of the shift that this takes for us in mental health. It's really a change in perspective when you talk about the population versus the individual. So it's sort of the unit of analysis. A lot of our work and a lot of our articles and things and literature is talking about the individual clinician addressing an individual patient's needs. But when you move to the system level, you have to address the needs of the population that you serve. Okay, so what would be the target population for us, right? I think what we talk a lot about, or what I hear a lot about, is the Bay Area. So we're here in San Francisco, but in terms of where we draw our populations from, it actually comes from the whole Bay Area. And at many times, especially that Brian has been talking about in autism, it's the world. So that's a broader view of who is going to come see you and who the target population is, given the condition. Okay. All right, so understanding the characteristics of the population, that's the basic thing that you need to know when you're starting to implement and design services. So you need accurate demographic data, and some of the examples I said: age, ethnicity, race, gender identity, preference, socioeconomic status, incidence, prevalence of mental health disorder, and illness burden, because this also is something we haven't talked as much about in mental health, but we know that having a mental health disorder has a huge impact on a medical disorder. We know that happens with diabetes. We know that happens in cardiovascular illness. And the literature shows that when you improve the mental health condition, you also help the medical condition, the comorbid condition. And we can't even talk, I mean, a huge area of substance abuse and addiction is another one in here that's sort of the elephant in the room in terms of what we're doing to deal with that, and I can talk a little bit more about that later as well. Okay. So what do you do when you have a population approach? What do you want to look at? Well, you want to look at risk stratification, so identifying groups that may need special programs and interventions. So what you have is a system trying to figure out what it needs to provide for the population who are coming in to be seen. So high utilizers are one group. That's happened with our ACO right now, with the population health people at UCSF have decided to target the high utilizers, primarily because they're very, very expensive, but that's not the only reason to do that. But you do want to know who's coming in to see you a lot, because it may be for a proxy for something not going well in their care, that our approach may need to be changed. So you do want to identify these people and figure out why they're utilizing the system more than not. Self or other harm, and of course that's targeted for level of acuity, public safety, as well as individual and family safety. At-risk social factors such as homelessness, justice system engagement, foster care, etc. So you want to know that about your population. You may have, well, we know in San Francisco this is a big deal, right? This is also a big deal, justice system engagement. And how do you interact with that population in a way that increases health and functioning? And then foster care as well. And then any kind of other special needs, such as, various disabilities and chronic illnesses of childhood that are brought into the adult setting. So you want to find out what that percentage is in your population and have that determine what kind of resources you need to devote for those to that condition. Okay. So let's move into how do you assess a system. So I've given you sort of the preamble of sort of the issues, but how do you go about assessing a system? Well, I like the kind of ecosystem approach because in many ways I see organizations as kind of living systems. They're made up of living individuals, and you have a lot of behaviors that go into that. The general definition is a complex network of interconnected, interdependent elements. And we often don't appreciate that it's interconnected, yes, but interdependent, yes, so that your behavior actually affects what happens with other people in your system. Now, we should know that, right? But often we don't. We know it at the individual level, but we don't really know it at the system level. But it's very, very active at the system level as well. Technical definition, and I'm a biology major from college, is a biological community of interacting organisms and their physical environment. This, I think, is really important. We know the impact of the physical environment. So, as you know, we've done some modifications on the inpatient unit. It makes a difference what kind of environment you come into for healing. You don't want that to be a dour, kind of depressing place when you're already depressed about something, and this is where you're coming to be healed. So the future will be, and Lowell working on our new building, is you want someone to come into a pleasant, uplifting environment, because that makes a big difference. And we in mental health need to pay much, much more attention to that. That gets into your offices. I remember when I was a resident at UCLA, one of my supervisors came in and he said, "I'm glad to see all your plants are living." And he said, because it's very hard for a patient to come into a room and to see someone with dead plants. They wonder, is this person really paying attention? The other thing he told me is, he said, don't have out-of-date calendars on your walls. Because people come in and they say, wait a minute, I'm seeing you and the calendar is not even updated. And what kind of attention and care will I get here with the clinician who seems to be a little bit distracted? So I thought that was a good find. So an example of an ecosystem is Facebook, I think we all know now, is an entrepreneurial ecosystem. We kind of thought that they were just trying to, people connecting people, and everybody was feeling really good about that. And then you found out that their financial model was to mine your data and sell it, right? So it's definitely an entrepreneurial ecosystem. And now they're really trying to figure out how to do that. I think Facebook is a wonderful thing. I'm not on it. My husband is. He loves it. But we found out that there were other aspects to it. Okay. There's some distinctive features of the mental health care and the system. We deal with stigmatized conditions that may make it difficult to engage patients, complex forensic issues such as involuntary care, less well-developed infrastructure for measuring and improving the quality of care. This is a big one, which we're trying to work on. And as you know, we've hired a data analyst to help us do that, to collect data and mine data. Multiple organizations, systems, types of clinicians providing mental health and substance use care, and we're often not well coordinated in terms of all those areas. Less widespread use of information technology, which in this era is really going to be a danger, and a workforce with more diverse educational and training backgrounds. And sometimes we haven't level set about how each group contributes to the overall health of the system. And we have a differently structured marketplace for purchase of mental health and substance use disorders, and this is a threat in terms of the financial issues that we deal with. Okay. The additional mental health challenges that mental illness is often poorly understood, and the impact on other aspects of health and healthcare are often unacknowledged because of lack of education, denial, and stigma. And where you see that is often when a system starts trying to address how to allocate resources, mental health's at the bottom, because they see us as not needing very much, when in fact we in many ways need more, because the mission of the institution has to include mental health, but often it's a sort of hidden mission and not acknowledged in the way it should. So we need to talk, educate across the communication divide. And I feel that's a lot of the work that I do actually in UCSF Health, and Brian and Matt and all of the others, in terms of educating people about mental health needs, and the importance of that. Okay. Now, in terms of assessing the quality of a particular ecosystem, one of the first models looking at that was the Donabedian Model. And the model, people have talked about that it needs to be a little bit more complex, but he started working on this model in 1988, and then he had the seminal paper on it. Actually started working on it 10 years before, but this is a seminal paper talking about the quality of care, how can it be assessed. So it was a first pass look at that, and he said we need to divide up the model at looking at structure, which is often the administrative structure, how you structure the care, what kind of clinics you have, and administrative structure is turning out to be much more important. It's like the skeleton of care, And so if the skeleton's not working well, if it's not very mobile, it's very hard for you to hang the other things on it, the muscles and the rest of it. So process, that would be the policies and, the algorithms and the kind of things that help you figure out how you're going to provide the kind of care. And then the outcome, of course, is the outcomes of what we do. An example of a process is that Plan, Do, Check, Act, which you all hear about in terms of improving systems. Okay. And how to determine the health and effectiveness of the system is basically on outcomes. And this is a growing area in mental health, figuring out what outcomes are important and figuring out how the best way to measure them. We're really just trying to figure out a lot of these things, even though we have new rating scales. So we want evidence-based rating scales. That would be PHQ-9 and the anxiety scales and things like that. Ultimately, that's going to need to be used in regular, everyday care, in terms of assessing what's happening with your patients. Patient satisfaction, we do measure that. If you've been looking at our True North board kind of sheets, we talk about what people are feeling about their inpatient care and their outpatient care. You have to measure that because that determines whether people want to come back and see you, right? So, and then finally, the different domains of satisfaction with communication, with, availability of contact when they need it. Clinician satisfaction is a big one. And a lot of work is done here at UCSF looking at that, measuring clinician satisfaction, measuring burnout, looking at that. It's one of the things I think that's really happened in my lifetime of practice is that it's gotten much more complex. I mean, the feeling when I started out was that we had much more autonomy in terms of what we did. People weren't looking over your shoulder. The electronic medical record was just really coming into force. So we could document what we wanted, right? And no one was really looking at the charts. But now it's very, very complex. I still think we need to do a lot of work with the electronic medical record because it's awful. You just have to put too much in there. The templates are there. It's hard to do it and think. And so I think most of us went into this work because we like to think and we like working with patients. But I think our systems actually are not set up in that way to enhance that. I think a lot of the burnout has to do with that because you feel like you're just filling in, blanks rather and not being able to step back and really think about what's going on with your patient. So I think that's an area that's ripe for some creative work for all of you residents who are trying to think about ways to do research and figure out what would really help. If someone really worked with the electronic medical record, I think that would be good. And it's a big dissatisfier for people both in academic institutions and outside of academic institutions. Okay. These are basically the elements that drive change by affecting the components of a healthcare organization. We talk a lot about mission, vision, strategies to set the organization's direction and priorities. But in truth, this is very, very important. This is how you decide why you're here. We are here to provide care for people. But one of the things that drives our mission is that we take care of the most vulnerable of the vulnerable. So that means it has a system that has to have those supports in place to really identify the issues of vulnerability and try to help mitigate those. It's not always about cure, but it's often about mitigation so that people can increase their functioning and both in their family, in terms of their work, and in terms of the society. A culture that reflects the organization's values and norms, and I'll talk a little bit more about that. Operational functions and processes that embody the work done in patient care. And infrastructure, this is a big one, that supports care delivery. And we're trying to get that right. We're looking at information technology, human resources, fiscal services, and facilities management. This is the one that kind of gets ignored, but that's where you live every day in terms of your office and your resources and things that you can have available so that you can get your work and not be distracted by saying, oh, I don't have this, I don't have that, the building's not working, Okay. All right, so this is sort of where the rubber meets the road in terms of looking at a system. Identifying the domains for intervention. Really, you have to look at these and decide where do we want to start first in terms of assessing the system, but then deciding what we need to do to get it right. I'm sorry, my back is to you. I'm trying to. So you'll see central is leadership. And then you have look at models of care and care delivery. Are we using the correct models of care? I talked about having embedded psychiatrists in primary care, integrative and collaborative care. That's a different model of care and care delivery. So it's moving it out of the mental health system into places where people are. See, I think the future is going to be that people get all of their care circles around the patient. We're not going to have patients running all over the city to have to see this person here and that person. I mean, who wants that? And it's just not going to work very well. I think it's going to be the clinicians and the services unavailable, so the patient goes someplace and we all move around instead of the other way. I think in 50 years, people are going to look back on what we're doing now and say, that's crazy. Why would you do that? Why would you have this patient spend 5 hours for a 30-minute visit, right? So we're going to have to look at that and figure out how to implement something like that. Policies and standards, it's vitally important for us to keep the policies updated to reflect the reality of what we need to do in the system and the standards of care, because that's continuing to change. Where you see that a lot is in terms of medications, psychiatric medications. We now find that a lot of our medications have, not now, we've always had medications with significant side effects, but measuring them in the record, we have policies that guide that we need to do that, like metabolic state, measuring that, making sure you know what's going on with that. Medications, making sure you have drug levels and that's available. Policies that dictate that. Information and data, that's pretty self-evident. You need enough information about what's going on. You do need to know about your patient and the population engagement. This has become a very big thing, and soon I think that's going to be one of the measures that systems are supposed to report in terms of what are you doing with the community? Do you have special outreach to the community in terms of patient engagement? Do people feel like they have a say in what's happening here? Organizational capacity, that's the big one, and what we've been looking at, my fellow vice chairs and I and Matt, looking at organizational capacity. Do we have what we need to try to get us where we'd like to go? And a big one is institutional culture, and it's a real important aspect of organizational capacity when you're measuring that. So institutions have social and behavioral norms, right? And I don't know how often we think about that in terms of Langley Porter and what our social and behavioral norms are. I think it would be an interesting dialogue to have about that. Some of the descriptions that are used, is it a very hierarchical culture? Is it formal or kind of informal, highly competitive, sort of lone wolf? And what works best, and what are people comfortable with, Environmental characteristics of the culture. Is it a collaborative culture? Is it highly competitive? Is it silent? All of those things can tell you what's going to work in terms of moving the system forward. And a cultural identity, I think our cultural identities, we're number one. I hear that a lot, right? And so, but looking at that and seeing, does it work? Does it not work? Does it work for what we need to do when you have to, because of the environmental circumstances, let's say financial circumstances are forcing us to change with things like increasing productivity, which I know you all have feelings about. How do you do that? What culture helps you best do that? So, next up. What Peter Drucker said, who's a big businessman, and I found this to be true. The older I get, the more I see this to be true. Culture eats strategy for breakfast, operational excellence for lunch, and everything else for dinner. Now, why do I put that slide up there? It's because we have to address culture. We have to make it more transparent to figure out what is our culture, what's the kind of culture we want, and how do we change it? If it's not at the level that we want it to be, if it's not going to help us get to where we want to go, how are we going to deal with this? Okay. So system levels, when you talk about strategy, a system level question would be current state. You need detailed information about the current state. You have to identify what's the crucial data that you need to help you make decisions. Future state, where do we want to go? Short-term and long-term priorities, objectives, and goals. And short-term is usually within the year, 2 years. Longer term is 5 years, 10 years, 25 years. And actually, that process we should be going through is to figure out where we want to be in 25 years. do we have the resources to get there? And this is a statement that Talmadge King loves to say, no margin, no mission, meaning that you can have really great plans, but you don't have any resources, it's really not going to go anywhere. Basically, what you have is sort of dreams, but no ability to implement your dreams. Okay. One of the really important organizational assessment tools is a SWOT analysis. And that's basically looking at your strengths, weaknesses, opportunities, and threats, and the threats that are internal and external. Internal threats can be finances, but it actually can be culture, depending on what's happening in your environment. Okay, next. So this is just an example from the VA, and it was from a system where I was, and we went through a SWOT analysis. So our strengths at that time were considered a high level of clinical competence, and we judged that by peer reviews. Peer reviews are really very good. Dedicated staff, strong academic affiliation with residents and medical students, strong psychology training programs, strong mission and core values. The weakness was that our sites were, at that time, very poorly aligned. We had many sites, and everybody was kind of doing their own thing. And so some people were really good, some people weren't, but they all thought they were really good because they had rationales for how they were doing it. But when we started measuring outcomes, we found that there were widely varying outcomes. Inadequate models of care, and at that time, that VA had a lot of general mental health, but no specialty programs. And so the population, if you can think about this is a VA, and you know, if you look at the target population for VA, it's warriors, right? And so they didn't have really sophisticated developed PTSD programs. They didn't have programs in terms of military sexual trauma. You know, all of the things that you would say that target population, you would actually definitely want that. And so that was remedied pretty quickly. And it also lacked a culture of continuous quality improvement, which is hard. Most of it had to do with just people not knowing how to do it and not understanding the importance of it. And everybody kind of saying, well, I'm doing a good job. You know, why do I need to worry about everybody else? But in fact, sometimes we think we're doing a good job and we are doing an adequate job, but we may not be delivering the highest quality care that we could. Opportunity, there were a lot of mental health funding initiatives that came into the VA in the 2000s, and that helped. And then mission-critical threats were inadequate staffing levels to meet the demand, because this was during the war of Afghanistan, and so there wasn't enough staff to take care of all the people who were coming back. Okay, let me speed up a little bit. Why don't we go on, because I know I want to leave questions. So I'll move on to talking about Department of Psychiatry and Langley Porter in our triple mission, which means we have a more complex mission than, let's say, someone like Kaiser, who's really there. The population they're dealing with are employers and employees. And so, although they have education and research, that's not one of their core missions. The core mission is clinical care. Our core missions are clinical care, education, research, and they're all interacting all at the same time. But what I'm going to focus on today is the clinical care aspect of that. What I had down there is about a SWOT, but when you're moving forward and looking at a system level, you need to look at a SWOT for each of those areas independent of that. So, clinical care access. The first day I started, I met with Sheila Antrim over at UCSF Health, and what she told me is, she said, you know, in real estate, the answer is location, 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 right? She said, for you, it's access, access, access. She said, that's what you need to pay attention to, because one of the core issues that we were dealing with at that time, and we're still dealing with it, and trying to improve that, is access to mental health services for even the population of UCSF Health, not even the rest of the city, right? Next. So this is where, you know, sort of psychiatric help, too expensive for you, the doctor is out. This is often what happens. Okay. So if we look at mental health treatment among adults in California, what you'll see here is that even the best don't get very much, right? So this is minimally adequate care. This is some care, and this is no treatment. So you see there are huge numbers of people who have disorders who get no treatment at all in California. That was the latest data I could find at the time, was 2000 and 2009 combined. And it was from the California Health Interview Survey. So you see it looks quite bad. So, okay. So what are key access questions? One is, how long are people waiting for initial appointments? and follow-up appointments. That's a key basic indicator. Do patients have access to services indicated by their condition? Acuity level. Do patients have access to the appropriate intensity of services? Okay. So all of those are elements. And a key systems question is efficient use of available services. Despite staffing problems, are clinics efficient? Meaning clinician schedules appropriate, patient wait time in clinic to be seen, that should be, to see the clinician, no-show rates, and the scheduling process. And as you know, we've been working on all of those elements. And developing mental health specific quality performance metrics, access, timeliness, process of care really has to do with guideline implementation, evidence-based practices, best practices, outcomes measures, which you want to look at, it's illness, remission, recovery, social occupational functioning, and patient satisfaction. Okay. So now we'll move down to Langley-Porter, hospital and clinics. In 2016, when I came here, the access primarily was determined by teaching clinic availability, right? Select access was via the faculty practice, right? Long waits to be seen for subacute and non-emergency care. New patients, it was really taking between 1 to 4 months, and it was sort of hovering around here for some. Established patients was also taking 1 to 4 months, determined by individual clinician scheduling practice, because there wasn't sort of a consistent scheduling practice. Limited availability of certain treatment modalities, such as group therapy. We had long waiting lists for that. If patients needed to be seen sooner, they were able to get emergency high acuity care, but it was generally via the emergency department. Some people saw their individual clinicians and got help, but generally they were sent to the ED. And non-emergency care, often people were referred to community clinicians or handled via direct request to individual clinicians. Okay. As of 2019, some of the structural changes, if you remember I talk about the Donabedian Model, and you look at structure, process, outcome, some of the structural processes that we went through to increase access is there are faculty direct care clinics and outpatient now, and new outpatient clinic staffing models. We've expanded the use of advanced practice nurses. You know, the outpatient clinic now has 2 nurse practitioners. Expanded use of RNs and medical assistants in the outpatient clinics to try to help the care in the clinic. And this is new, but we will be expanding this as we move along. Enhanced ability to provide individual psychotherapy. We're looking at that. Enhanced ability to provide group therapy. And implementation of productivity standards. We're just in the very early phase of that, looking at that. And then by primary area of focus, meaning that clinical research and teaching may have different WRVU expectations, given what their work is. The external environment, which is what I mean by the city, is we now have a locked facility to help with step-down care and to help decant some of the beds at Zuckerberg so that when we have people here who can't be seen at Langley-Porter, that they can move to that setting. Future structure of care, what will this look like? And this is some of the things we're thinking about. It's not written in stone. But expanded clinic schedule, standard evening clinics Monday through Thursday, that's been talked about, and the possibility of weekend clinics. Now, some clinicians have been asking for that, the ability to see patients on weekends, and that may mean flexing their schedules so that they do that, flexing their schedules to do that, but looking at alternative models in terms of how we provide clinic availability to people. New outpatient clinician staffing models, team-based care with team panels, so that it's not only the burden of the individual clinician to have a certain panel of patients, that a group would be responsible for a panel. When I was at UCLA, I worked for a while at a VA there, and they were implementing a research looking at what was called ambulatory care. It was called a global care team, and I was a psychiatrist on a team with primary care doctors, and we were responsible. There were 3 teams, red, blue, green team. We were responsible for a panel of patients, so it wasn't an individual clinician being responsible, but a group. And so we would have meetings around the patients, and what happened is the patient satisfaction actually was really quite high because they felt there was a group of people who knew their care. So when they came in and their clinician wasn't there, there was someone who knew about them. so they didn't wind up having to tell their whole story all over again, which, as you know, patients complain about a lot. They say, don't you have the record there? Can't you read it? Why do I have to tell you, over and over again? But I think that's going to be a more efficient way of doing it, and I think the satisfaction for clinicians is going to go up once we start doing something like that. So this is something we're looking at. And expansion of the collaborative care model. We're being asked by other departments to expand that model. So we're working on it in primary care and looking about expanding it there. But now we're getting queries from OB, and in fact, we do have someone down there. But OB-GYN really wants that expanded. Interestingly enough, when I first got here, I was talking with some of our OB people, and they were saying that the incidence of domestic violence reporting goes up when a woman's in labor. And so what they were having is a woman was there when her spouse or significant other was not, and they were then disclosing it because they were worried about bringing the baby home and trying to figure out what to do. So there's a whole population that we need to help with that. It just surprised me, and I asked some friends who were in some of the OB nurses, and they're saying, yeah, it happens all the time, and we never know what to do. We call the psychiatrist because then we don't know how to send them home, and, how are you going to send someone with a newborn to a shelter, and so all of those issues come up. But so they're asking. Interestingly enough, the surgeons are now recognizing, that sounds not good to say it that way, that surgeons are very good people, but I thought it was really interesting. They were saying, we need psychiatrists. I thought, wow, this is a new world. Because dealing with patients' recovery, because when the recovery rates for cancer, significant cancers, go up, they're starting to realize that there are a lot of emotional issues that they have to deal with, not only with the patient, but also with the patient's family, and what to do about that, how to handle that. And they're seeing the literature about support groups with cancer and cancer survivors, and so they're definitely on board with that and wanting us to help them with that. So I think we're going to have, I hope, we're going to have a real expansion of the collaborative care model throughout the system. The inpatient model, it will be impacted by relocation site, as Andrew knows, but we're talking about increasing the number of inpatient beds to meet the need. Our city has very few inpatient beds for the population that's here. Really, really not enough. So we need to address that in some way. And then we're also talking about having med psych designated beds to try to address those needs of the population. We have an aging population with an increase in comorbidity, and people do need to be hospitalized. Often right now they're hospitalized on the medical units, not on our units, but we'll have to see whether that's going to be something that we look at. Okay, what's the next one? Let's see. Evidence-based care. We want to improve that. Medication management. Medication management is wonderful, but we need more. And the psychotherapies, these are the evidence-based psychotherapies. I won't go through that because you already know those. Objective measures of assessment and treatment. So we're talking about figuring out how, in the medical record, to have people use rating scales. I think the state of the art is going to be a person being able to go on their iPhone and fill out the scales, and it's automatically downloaded in our record so that we don't have to go through all this kind of thing of filling out a piece of paper and then somebody scanning it in and all that. We're here in Silicon Valley. That should be something, a no-brainer that we should be able to do. And so that people could come to their visit already with that ready and already having it analyzed on your record when you open it up. We're talking about having a telehub system for consultation and assessment, treatment and follow-up. This is to deal with the travel issue again. Some of our people are homebound, bedbound, not always bedbound, but sometimes homebound. And then destination programs. And I'll try to, why don't we go to the next one? So program development, which I know you're very, very interested in. Mood disorders. We're going to have a treatment-resistant depression program. Substance use disorders. I think some of you may know that we're talking about having a pilot with a company to provide telehealth services for addiction throughout the system, but also for mental health, because the need is so great, we can't wait until we just simply recruit people in to establish a program. Adult eating disorders, we have a wonderful program for child-adolescent, but we need something for adults. Psychotic disorders, Damien, we already do have that, but we need to look at that and whether that needs to be expanded. PHP, IOP, focus programs, addiction, first responders, that's a target population that's not looked at very much, that really has a high burden of disorder. We've been hearing a lot of conversations. I've And Sarah goes, there's a group in San Francisco that works with the police department. They have a crisis intervention treatment program. We're now starting to see an increase in the suicide rate among first responders and the illness burden. And so I think this is something that we need to look at in terms of trying to help them heal, but also help them stay on the job and function in a healthy way with the population. Interventional psychiatry, as we know, Andrew Crystal is working on this. We do have ECT, but TMS, ketamine, deep brain stimulation, those are all on board to have within the next few years. Concierge practice, we're going to talk about that. As you know, when I talked about the world and our area, we have a lot of people who want to come and get treatment here. Some have a huge number of resources and special needs in terms of people who the media may be interested in finding out that they went to see us. So we may have to develop a practice to help treat that population. And then precision medicine is on the horizon, and Matt can talk a lot about that in terms of what will happen there. But that's going to be the big disruptor, I think, in the next few years in terms of how we practice, in terms of our policies, in terms of what we offer, in terms of how we treat. Complementary medicine program, we're now talking with people about having acupuncture and things like that available to people and studying that. I think that as we move into being a true future state-of-the-art program, we should have that available and have research going on where we contribute to the field. So I think maybe what I'll do is I haven't left this up, precision medicine. Why don't I stop there and sort of take your questions? I know it's been a lot of information. Any questions? Thank you. Thank you. You're very kind. Do you have any questions about all this? It's a lot, I know. Yes.
In an environment where in all treatment settings we're being asked to do more with less, and in a setting where we can't seem to find the staff to fill clinical responsibilities that we already have, like how we will manage to hire, like where is the staff manpower going to come to do all of these things, and like how are we going to recruit?
Okay, so where are you working right now?
I'm on AIP right now. I'm one of the residents.
Okay, so you're wondering from the residents' perspective, are you worried that the burden's going to fall on the residents, right? They're going to have to do all this, right?
Faculty and mid-level perspective, we don't have staff in some places.
We don't now have staff, and it's going to be our burden to increase the staff to do this. We're not going to be able to do this. You don't need to worry about us imposing this on residents to do that. Residents can't bear the burden of doing that. We will have to have staff available to help with this. So a model can't move forward assuming that the residents are going to do all the work. That's just not going to work because you're here for training and you're here for an apprenticeship. And so that's your goal and your need. This would have to be a staffing model that would meet this. Yeah.
From the standpoint that, I know that we don't have, there's a nurse practitioner in ED that we don't have coverage for, and we can't find coverage for them. How are we going to find more people to fill these roles?
Yeah, actually, we're trying to recruit. The nurse practitioner in the ED was a new role, and the reason why she's not there now is because she's pregnant. And so the person who was her coverage also had a baby. So those are the details of it, but those positions are there to be filled. And so the burden on us is recruiting to fill that position, to make sure that person is available. But that was a new position that was there. That wasn't there years and years ago. So the burden is recruitment, right, and making sure we can hire people to do that. And that's one of the threats. If we're not able to recruit and hire people to do those, then parts of this will not get implemented, right? What's changing with recruitment? Well, what's changing with recruitment is that, number one, we're recruiting. And the fact is we have to have the resources to do that, right? And so far we've been given resources to do that. But recruitment is it's a short-term and a long-term. But I think we're doing pretty well. We decided to recruit nurse practitioners 2 years ago, and they're both in the outpatient setting. We recruited, as I said, for the ED nurse practitioner, and there was another one. But you always have the vagaries of people's lives in terms of having to go out to have a baby and needing maternity leave and things like that. Does that answer your question? Okay. All right.
Expansion of services. Is there
the future plan?
The future plans.
Right.
Any plans to provide more contracts with Medi-Cal so that we can really reach the most vulnerable?
I think that would be very nice, and we're trying to figure out how to do that. We actually do provide a lot of care for Medi-Cal, but it's uncompensated at this point. And the issue is financial sustainability when you provide a lot of uncompensated care. So we have different models. The embedded model allows us to see some Medi-Cal patients. Some of the details are sometimes philanthropy can help a little bit about that. We're dealing with that with the cancer patients, but it is a big problem. It really is a big problem. Okay.
Just with the embedded care, what is our financial model with that? Do we need a sense of, are they more typically are people that we pay incentive?
There technically are people, and they bill, and they bill. Although one of the other models is having those departments pay for their services as well. And so it works better for Medi-Cal. If they're willing to pay us directly, then we can have them see Medi-Cal because they're paying us for their time, and then they bill. And so they're kind of complicated.
Okay. So one of the issues now as well is if there are employees, they really can't see Medi-Cal even though they're embedded in other pathways.
Yeah, it's harder. What winds up happening really is you do the right thing, and then we have uncompensated care, which has been one of the drivers of our current deficit. So, we hear a lot, we don't take Medi-Cal. Well, yeah, actually we do. We just don't get paid for it. And so the issue is to try to figure out how to do that. There's some models you can contract with EPH and look at that and see how that works and figure out how to do that. But we do need to, that's a huge problem that we do need to address.
Very interesting. So there are several things, when I look at things nationally, I think there are several movements, and you kind of included them, but I wonder if you could comment. So one of the things is collaborative care, and I'm not sure, and this is partially for the training. So what we are doing is embedded care primarily.
Well, we're also doing collaborative care.
Well, let me just, so embedded care is where it's essentially like the service, as you were just saying with Medi-Cal. You're seen there, and you get paid. The more service, the more you get paid.
Right.
The collaborative, what is called the collaborative care, is very, very different, where there's a certain amount of money that's paid for a service, and you don't have psychiatrists providing that. You don't have them in clinics. What you do is you train people. They may be nurses. They may be people who can learn the evidence-based treatment. You have a psychiatrist supervising, especially the more complicated patients who have short-term treatment. And the intent of that is to save money for the system, which we're not, since we're still mainly fee-for-service.
Yeah, actually the model is moving forward and developing. And Margot may want to comment. She's actually our Associate Director for Integrated and Collaborative Care about our models. Yeah.
Trainees. The
I think it's important for Margot to address some of the points.
Yeah.
Because that model is moving
But you said the
forward.
trainees, there are different models of it. It depends whether you're paying like in canopy care where a certain amount for, all the care, and you want to keep the, and then the other thing that you have spoken a little bit about, but is very prominent nationally, is the use of telepsychiatry.
Yes.
And I know we're doing more of it.
We're behind.
But when we look 50 years ahead, or I don't know if it's 50 years ahead, I think it's 5 years ahead, the growth of that, it's not so much that we will be going to, which will also be the workplaces and to schools to provide the care, it's that people can stay in their home, not only if they're disabled, or if they're homebound, or if they have little kids at home, but just for convenience, especially with new generations.
Yeah, actually that's happening with students right now, with student health at UC Irvine and a couple of other places. The students do it all by FaceTime on their phones.
Third thing, which is sort of hit upon, but years ago the model of care was really what was going on individually, intrapsychically, and that we could help people. I think the movement now is much more to what people call structural formulations, to culturally sensitive care, to helping things in the environment before you can even start to help the person individually, to pay attention much more, and you've addressed this, to diversity, to the social determinants of health, and that until you start treating that, nothing else really matters. So you would
And you can do both, right? You can address the personal issues as well as the demographic issues and things like that.
comment on some of those factors.
Okay, all right, thanks.